Hello and welcome to Bristol Health Cares. I'm your host, Kurt Barwis. I am the president and CEO of Bristol Health. This program is for you. It's really about how you navigate the system of care, how you access care, and it's really about trying to answer questions you may have and really didn't know who to ask. We are going to bring to you professionals, doctors, surgeons, other healthcare professionals throughout our system of care, maybe people that you've never talked to before or met before, but the goal is to really help you understand how to access care when you need it. You're going to enjoy this program. This program is really for you. So what's important is if there is something that you want to learn about or know about or a guest that you'd like me to host on this show, write us and we'll try to make that happen for you. So enjoy the program, Bristol Health Cares. Hello and welcome to this episode of Bristol Health Cares. I am Kurt Barwis, your host and the president and CEO of Bristol Health. Today we have this amazing show with Mark Schaefer, who's an executive with the Connecticut Hospital Association. Mark, welcome. Tell us a little bit about yourself.
Well, I am working for the association now to focus on issues related to Medicare and Medicaid reimbursement, and also on a strategy for hospitals to become regional agents of transformational change, basically to become bigger than what they do in their, in terms of inpatient, outpatient care. So that's what I'm doing today. I have a long history working for the state, for Lieutenant Governor on payment reform, and before that was Medicaid director for several years and did a lot of stuff on Medicaid. So I'm delighted to be here and eager to hear what you have to ask.
So your world's really kind of interesting and for the viewing audience, so let's talk a little bit about transformational change. Use that word and looking at different models for reimbursement. I wonder, like, if you could kind of explain that in easy terms. I mean, your world is very complex.
So for 60 years now, healthcare has been paid basically, whether you're a physician or you're a hospital. You do stuff and you get paid when you bill for it. So you bill for an office visit, you bill for a knee replacement, et cetera. So that's the sort of bread and butter, the sort of way healthcare has been financed. And mostly that has meant that healthcare delivery systems grow to meet demand, and they can bill and they can cover their costs, right? Which is critical. In the 90s and early 2000s, there were concerns raised about the quality of care, and there were concerns raised at the same time about the cost of care. And so out of that concern about the outcomes we're getting from the care that's being provided and growth in costs to become today around 18 or 19% of the gross domestic product has led to innovations in payment models. And probably the most widely adopted payment model is called the accountable care organization model, which most people, they may be participating in this model and have no idea.
Yeah.
And under that model, basically, you take a group of primary care docs who are all together and they're affiliated under some practice umbrella. The Bristol Health physicians would be an example. And a payer like Medicare says, you have 10,000 patients that are Medicare patients that you take care of. And so we're going to measure the quality of their care. Do they get their well visits? Are they getting their colonoscopy screenings? And how are their diabetes outcomes? We're going to measure that. And we're going to also look at how much those 10,000 people ought to cost next year. Using the same techniques in insurance, how much will this group of people likely cost next year? And we're going to use that as a benchmark. And so if you can improve quality or do quality, get outcomes that are better than the average, and if you can spend less caring for these individuals than, say, we would have predicted, you get a share of the savings. That's the basic model.
So let me kind of just say it back, just the way I hear you say it, and I think it's really important for people to understand. So you started with the way the payment model works. So you go to see your doctor, you go to the hospital, you have a procedure, patient gets the procedure, and the insurance company, whoever it is, Medicare, Medicaid, commercial insurance, they pay the person who provided that service. And the transformation that started many years ago, decades ago, was really about how do we shift the thinking and the way we take care of people to really focus on quality outcomes and help a population become healthier, saving that fee-for-service cost, and rewarding those physicians and hospitals who create systems that really, and sometimes it's a pain in the neck. They call you up repeatedly. You didn't get your colonoscopy. When are you going to schedule? Can we schedule your colonoscopy? Can we do your breast screening? Can we do all these things? How was your A1C today? And did you take, what are you eating? And, with all these different disease states that people have, congestive heart failure, you didn't get into the pickle jar today, did you? And what's your weight? And things like that. So it's this concerted effort by the system to be more than just the provider of the care, but to be a partner with you in improving your health so that the cost of care is moderated or starts to kind of level off. And as a society, as a whatever group it is, we get better, we get healthier, we live longer lives, we do all that kind of really cool stuff. We want it, like pickleball when we're older and stuff, right? I mean, that's the thing. Does that make sense?
Yeah. Yeah. Now so there's another way you can try to control costs and manage quality, and that's by paying a managed care company to control costs and manage quality. But those payers, those managed care companies, struggle to do that because they're not actually with the patient providing the care. So the main tool the managed care companies bring is to review what you do, and when you order an X-ray or you order a knee replacement, you have to call them to get permission because they're trying to reduce the number of what they would call unnecessary procedures. So that's another way you can try to control cost, and it's effective, although it's also super inefficient.
Oh yeah. And
there's a risk that people will be denied or necessary care will be delayed. So there you've got this approach of managed care, we'll call it, and then you've got this approach of payers partnering with physicians and other providers so that they can partner with their patients to help keep people out of the emergency department through exactly what you're talking about, which is troubleshooting the asthma management issues that would lead somebody to end up in the emergency department. Now, there's a twist, but I'll wait for your next question that I will.
Well, no, I just think it's so. So this gets back to the innovation and different models. So on the model where you're creating the right incentives to go out and take care of the population's health, you can go at it with, and we look at it as we get quality incentives, for example. So you may not have a gatekeeper, you may not have a managed care plan where you need all those authorizations and approvals, but there's a balance sheet or a tally sheet of how did you do with this population that you have? Could be a commercial insurance plan through your employer, whatever. And at the end of a period, they say, you did really, really well. We're going to provide you with an incentive payment for what you did. Or you can have a straight, kind of HMO plan where, like Medicare Advantage, for example, where the gatekeeper piece of it is the key thing. We're going to review, we're going to approve, the dreaded prior authorization, which most people recognize. They go to their physician and the physician says, you need a CAT scan, you need an MRI, or you need physical therapy. Hold on, stop the line. We've got to call up. We've got to get a prior authorization. They want to review everything that happens. So it's two approaches to reducing cost. And I think one I struggle with in terms of quality outcomes and care. The other one I think is a very good approach to really kind of incentivizing doctors and hospitals to do the right things.
Good, but with a limit. So everything you said, in my view, about the downside of managed care is exactly on point. The issue I have with these advanced, what are called value-based payment models, we're going to pay you for the value you produce in your patient care, is that the cost benchmark they set is based on how sick your population is. So you use the term, they're going to pay us to keep people healthier, right? Yeah. When I think of keeping somebody healthy, when I think about my own kids and keeping them healthy, I think of supporting them diet and lifestyle so that they don't get they don't develop cardiovascular problems, they don't develop diabetes, type 2 diabetes, which is near epidemic in this country, right? So when I think of a healthier population, it's not getting sick, not simply managing somebody's A1C control if they're diabetic so they don't have crises that lead to the emergency department. Keeping better care for sick people is different than better health.
Right, I got it.
And the models today, when they set that cost benchmark that you have to try to beat to share savings, is based on how sick your population is. So you actually have a better financial opportunity if you have more sick people in your practice, more people with diabetes or congestive heart failure, COPD, asthma. So these models today, the most prevalent models nationwide in commercial and in Medicare and in Medicaid, actually don't reward you for having a healthier population. And to my mind, that is a fatal flaw in these models that needs to be addressed, or we're never actually going to create a market that rewards keeping people healthy.
No, it's a really interesting point. I never really processed it that way. I mean, but it kind of makes sense, because if you look at Medicare Advantage, they get paid from the federal government, their commercial plans, and they get paid a fee every month for every member, and it's based on an assessment of their health status, right? It's, they go through some calculation and say, this person's really, really sick, has chronic conditions, has all this and that, and it gets them a bigger number, right? And so I think what you said is absolutely true.
So some industry observers would say that for a Medicare Advantage plan to succeed in its market, in its business, they have to figure out how to load up the diagnoses onto the patients so that they can maximize their premium revenue from the payments they get from the federal government. So there's two ways you can succeed in these models. One is by more effectively managing people who have various health conditions, and the other is by optimizing or managing how effectively you code diagnoses, which actually doesn't do people any good. It helps the managed care company, but it really has no benefits for the individual.
Yeah, I think that's really an important distinction from what we were trying to do to what we are now predominantly seeing in the models that are out there. And I think the thing that I struggle with the most is that often that gating that happens for these really sick individuals or individuals that require a lot of care, often the delays in getting the care causes harm to them. And it's really kind of hard for me as a healthcare provider, not a doctor or a clinical provider, but someone who is in healthcare my entire life, and to see and hear about people getting harmed by Medicare Advantage, for example, or we don't have Medicaid managed care in the state of Connecticut, but I struggle with what's happening what's happening when these people get hurt. Where's it going? There's really no reporting system where people just accept it because that's my insurance company. It's okay, right? But it's not okay. So there's that issue of the misaligned incentives, I think, is really kind of, I would sum it up that way. And the profit incentive that's now in this really been brought into our country in a big way, because you have more than 50% of the Medicare population is now on Medicare Advantage, which is all about shareholder value and profits. So anyway, so one of the things that people struggle with is, understanding, I remember talking to my parents about, well, I have Medicare. I mean, you got paid for that. And I don't think people understand that you're actually not getting paid, the doctor or the hospital is not getting actually paid the full cost of what it takes to actually provide the care they received. And then the same thing holds true for Medicaid. And the underpayment of what it costs is pretty significant. So how does that all work? I mean, and how bad is the underpayment right now?
So Medicaid is a national program that's run by states. And so when you talk about how bad the underpayment is, it's a state-specific question. So in Connecticut, the Department of Social Services, which manages the Medicaid program, has presented data that suggests that we spend about 21 or 22% of our state expenditures on Medicaid compared to the northeastern state average of around 28%. So we substantially underfund Medicaid. And that's to the tune of, you translate those percentage points into dollars, that's about a $2.5 billion underspend in Medicaid. That $2.5 billion underspend in Medicaid is problematic for a bunch of different reasons. One is because there's a cost to operating a healthcare delivery system that provides good access and good quality, not only to hospital services, but home care and physician services, right? And so that cost has to be borne by somebody. And to the extent that Medicaid is shorting their investment in the system, they're not shouldering their fair share, who ends up covering the difference? It's not Medicare. Medicare's rates are set nationally, and the payment is the payment. In the end, that $2.5 billion underspend every year is borne by the commercially insured individuals. It's borne by employers, small and large. It's borne by the employees who pay a portion of their care. It's in effect a hidden tax on commercially insured individuals. In addition, it's bad fiscal policy, because for every dollar we underspend in Medicaid, we're foregoing $1 or $1.50 in federal matching funds. So for every dollar we spend on Medicaid, the feds match it at about 60 cents on that dollar, right? So it's only costing the state 40 cents, but it's relieving the commercial sector of $1. The folks who are working every day and paying their insurance premiums, of a portion of them with their employers, they have to subsidize the full cost of the of paying for the service delivery system, whereas the state could use the federal dollars to help subsidize that. So we looked at 6 years of this $2.5 billion underspend and estimate that the state has left $7.5 billion of federal funds on the table for its lack of investment in Medicaid. That's a fundamental structural problem it's inescapable at this point. If the state's concerned about the pace of cost growth in commercial plans in this state, the number one thing it needs to pay attention to is how much it's contributing to what it costs to deliver care, not just in hospitals, but in physician settings, home care, behavioral health.
All of it, yeah. And so it's really quite extraordinary when you put it in the terms that you put it in. But essentially, the Medicaid program, which covers 25% of the population in the state of Connecticut, 25% have it. And when they go to get a service, what that provider, doctor, could be an orthopedic surgeon, whatever, is getting is a fraction of what it costs to actually provide that care. And if you step back, it's literally like free money could be had from the federal government if the state were to increase its rates that it paid hospitals, doctors, all the facilities in the state. And the federal government would then come in with and pay 60% of the actual total spend that we have.
That's right.
So we're leaving money on the table that could be put to good use. And I think, you know, part of the problem is access, because if you look downstream, so some physicians won't even take Medicaid. They won't take it. They won't. So if you need a hand surgeon, for example, rare that you're going to find somebody that's going to take Medicaid unless they're employed within a hospital physician group, which means that somebody, and I had this situation where one of my primary care physicians had 13 patients on Medicaid that couldn't work because they couldn't get to a hand surgeon that would take state Medicaid. So it's a vicious cycle, right? I mean, it's just really unfortunate for those individuals who really do want to kind of figure out how to get to a better place, but they can't and they have insurance, but they can't get the care that they need because of the underfunding.
Yeah, I think you point out what I completely ignored in my comments, which is it's not only a downside for the commercially insured individuals who have to bear that shortfall, that underpayment, but it also has implications for people who have Medicaid as insurance, who have Husky as insurance, because they don't have access, even close to the level of access to subspecialty and specialty services that commercially insured individuals don't. And that can have implications for their ability to get back to a level. Like, we would all struggle if we had unmet health needs in getting to and managing a day job, right? And that is critically important, is the access.
So Mark, this has been a very deep conversation. I think we're going to have to do this one again and kind of hit other sides of it. But so thoughts for the viewing audience, last comments.
My closing comment would be, we need to look at what the state's doing well in Medicaid, and I would say that its managed fee-for-service approach is super efficient. And to your point about timely decision-making around authorization, they have real-time decision-making, say for inpatient services, that should be the model for the rest of the delivery system. So look at what it's doing well, and then look at where it really needs to come in to right-size that Medicaid needs to. We all have an investment. Everybody, whether you're covered by Medicaid or not, has an investment in the state paying its fair share of Medicaid, because it's good for the people who are insured with Medicaid, and it's good for the folks who aren't and otherwise bear the cost.
No, it's great. It's great. Key point to make. And it sounds like we still have a lot of work to do going forward to get this right and to actually maximize the federal dollars into the state, which could dramatically improve the system. And it actually supports economic development. It supports, you know, healthier people, healthier residents of this state. I mean, there's just a lot of opportunity.
And I think as hospitals, we have ideas, specific ideas as to, you know, how we could put together a deal that would be to everyone's best interest.
Yeah. So stay tuned for that, because I think that's soon to come, right? So this has been Bristol Health Cares. And again, I'm Kurt Barwis, your host. If you have any suggestions of, you know, guests that you'd like me to have on the show, you can email me at cares@bristolhospital.org. Again, that's cares@bristolhospital.org. And also, I would be remiss if I didn't say a special shout out to Nutmeg TV. This is a nonprofit organization. They absolutely need your support. So please, you know, open your wallets, be generous with them, because this wouldn't happen without the public support. And thank you to this team here that's done such a great job of producing this show and bringing it to you in so many different places. They have this amazing all digital high definition studio that really does help communication, help you get to know what's going on in your own community. So again, thank you very much. Have a wonderful day.